The lecture you are about to see is part of our annual Alan Edwards Psychology Lecture Series. Professor Edwards was affiliated with the Department of Psychology for half a century until his death in 1994. He was an outstanding teacher, researcher, and writer who introduced new statistical techniques that are credited with changing the way modern psychological research is conducted. Alan also permanently enhanced the intellectual climate at UW Psychology by endowing the Alan Edwards Lectureship, which since 1999 has brought in an impressive list of renowned psychologists to the UW campus to interact with faculty and students. The lecture you're about to watch is one of a pair given back-to-back that matched a UW psychology professor with a visiting researcher to talk about a topic of great public and scientific interest.
Good evening. My name is Sherry Simoni, and I'm chair of the psychology department here at the University of Washington. Now, I'd like to welcome you to the 6th annual Alan Edwards series that we put on. And the topic of this year's lecture series is diversity, culture, and behavior. Now, before I talk about more details about the speakers that we'll be having, what I'd like to do is just take a few minutes to talk about how it is that these lectures came about in the first place. Now, these public lectures are made possible by a generous endowment by one of the former professors in our department, Alan Edwards. He spent 50 years of his career in our department, and he passed away in the mid-1990s. Now, at the time that he passed away, then his family made a very generous endowment so that we can bring in world-class lecturers through the psychology department and also to the university campus at large. Now, Alan Edwards is probably most well known in the psychology field for the fact that he brought statistical methods, rigorous statistical methods, to the science of psychology. And his textbooks have really become the gold standard for a number of different kinds of areas within psychology, and they still are used today. And so clearly he has made a name for himself there, but in addition, because of this lecture series that he's allowed us to have, he's now, his name continues to be discussed in a different light throughout the department. Okay. And we're very grateful for the family's donation. Now, the Edwards family contribution to the psychology department really exemplifies what can be accomplished with support from community folks such as many of you here today. I know that a number of you have made contributions to our department, and given our tough economic times these days, I just wanted to take this opportunity to say thank you, and that it really is making a big difference. Now, the psychology department seeks to take advantage of the unique collection of world-class researchers and instructors by facilitating interactions between traditional disciplinary areas within psychology, such as the cognitive psychology, developmental psychology, social psychology, and so on. We aim to foster a dynamic and vibrant synergy that leads to innovative solutions to the largest of societal problems. Now, this year's focus on diversity, culture, and behavior then exemplifies the department's unique type of interdisciplinary and collaborative and comprehensive research programs that use tools of behavioral assessment, neuroscience methods, social, clinical, and developmental theories to advance our understanding of the influence of diverse and cultural perspectives on psychological well-being and decision-making. Now, so you'll see that such a comprehensive understanding really is essential if we are to maximize individual as well as societal productivity. Now, tonight we focus on research, again, aimed at understanding issues in mental health from a global perspective, another multicultural perspective. Well, it gives me great pleasure to introduce Dr. Simoni, our next speaker. Just to give you a little bit of background, Dr. Simoni is a clinical psychologist who received her PhD from the University of California in Los Angeles. She is currently a full professor in the Department of Psychology here at the University of Washington, and she's also an adjunct professor in both departments of women's studies and in global health at the University of Washington. Now, within the psychology department, she heads our adult clinical psychology area as well as the practicum program. And she co-facilitates our Global Psychology Interdisciplinary Research Initiative, and she also teaches courses on minority mental health. Additionally, she runs an active program of research involving colleagues at both the junior faculty, postdoctoral, graduate, and undergraduate levels. And she's actively involved in the UW's Center for AIDS Research, where she's a faculty member of the Social Behavioral and Prevention Research Core. Now, over the past 2 decades, she's published extensively and has presented nationally and internationally on her research. And her research focuses on identifying how cultural strengths and social support bolster psychological well-being and resilience among stigmatized groups such as sexual and racial ethnic minorities and persons living with HIV/AIDS. Now, she has been very successful in securing several research grants from NIH recently, including recent projects on HIV medication adherence in New York City, Seattle, Beijing, and most recently on the U.S. Mexico border. Her research is obviously of high societal relevance on a global scale, and so we're very excited to have her here tonight. So, welcome, Dr. Simoni.
Thank you, Sherry. It's an honor to be here, and I'm very excited to talk about such an important topic. Dr. Van Dyke laid out a great rationale for why we need global mental health. I have the harder job of saying how to do that. I lost the coin flip on doing this, but I'll start with a little story about a Seattle neighbor of ours who was very ambitious, and his goal early in his career was to get a PC in every home in the world. Well, he soon found out that many homes in the world didn't even have electricity, and moreover didn't have tables or chairs. He soon switched in a more philanthropic approach, and now he's looking to get physical health care in most of the developing world. And if you think about his evolution over time, some of you may remember this from your Psych 101. This is Maslow's hierarchy of needs. On the very bottom, you have the physiological needs in shelter, security, love, and belonging. And then higher order needs are esteem, to experience purpose, and a need for self-actualization. I guess only a PC would be kind of high up here on the list. And I guess when I think about development aid organizations and the relationship between physical and mental health, they think that physical health is pretty basic on here, and mental health is way up at the top of the list. So let's go back to the laptop experiences. Now in Africa, they might not have access to a lot of electricity in many places, but most have access to the sun. And there are now solar-powered laptops. And the thinking by development organizations is that if we're going to get people out of dire economic straits, they need access to technology. You can't wait to get everybody fed and clothed and sheltered and then say, well, here's the internet. They need to work together. And this is how my thinking, a lot of the thinking in our communities has evolved around the relationship, the synergistic relationship between mental health and physical health. You can't have one without the other. So today I'm going to talk about some characteristics, the hallmarks of Western approaches to mental illness, different approaches that might be needed in low-resource settings, some of my research in the Department of Psychology, which relates to the HIV epidemic and medication adherence. I'll talk about projects in Seattle, China, and the U.S. Mexico border, and I'll end with some discussion of the movement for global mental health, which offers hope in what has been called really a catastrophe in terms of the mental health disparities. All right, Western approaches to mental illness. First, there's a very complex classification system in the West. This is the Diagnostic and Statistical Manual of Mental Disorders. It's published by the American Psychiatric Association. It lists 5 primary disorders: mood disorders like depression, anxiety, substance use disorders, cognitive disorders, including dementia, and psychosis. This is a very heavy volume. It's over almost 1,000 pages. So it's very complex. And what's interesting is that the first one came out in the 50s, and it was about 50 to 100 pages. Clear evidence that in the West we're becoming more and more insane. Not only is this a large book, but a lot of it is culturally biased in terms of the diagnoses. Now, some appear to be universal. There seems to be severe psychosis throughout the world. Major depression is seen in many places. It might manifest slightly differently from place to place, but you see underlying conditions the same, anxiety as well. Others reflect really Western values and norms. For instance, there are eating disorders like anorexia nervosa that affect mainly adolescent girls, where they actually starve themselves to death. And it's hard to imagine in a place characterized by food insecurity that you would have a disorder like this. Or there are personality disorders like the dependent personality disorders. Now, in a culture that's more collectivistic, it's hard to imagine you could be too dependent on someone else or too independent. But in the West, we've made a disorder out of that. What's interesting is the culturally bound syndromes, because there is a small section in the back for the culturally bound syndromes. They're only labeled if they're non-Western. So if they appear somewhere else, that's culture. Anything that appears in the West It must be real, must be biologically based or something. Also, there's a very narrow base for the evidence for our diagnoses. The research claims to represent all human beings, but really it's based on weird people. Weird people are Western, educated, industrial, rich, and democratic. In fact, most of the research is done with college undergraduates. You can take any American undergraduate, and they're 4,000 times more likely to be a research participant than someone selected in the rest of the world. Since 1986, 10,000 participants in psychiatric trials have participated, but only 561 African Americans, 99 Latinos, 11 Asian Americans, and not a single American Indian is represented in the field of psychiatry in terms of these trials. Fourth, there's a strong biological basis. The idea is that brain science is important and that most of our disorders are biologically based. It neglects the important social determinants of health that we heard spoken about before. Fifth, they're problematic diagnoses. They're complex, they're subjective, and even the framers, the authors of the textbook, admit that they're unreliable. One psychiatrist can make a diagnosis, another one doesn't, and comes up with something else. There are no lab measures or blood tests. You can't go to the doctor and say, what's my score in the schizophrenia blood level? Did I surpass that cutoff? It's not as simple as that. Also, there's a problem of compartmentalizing it. Psychological problems and treatment are divorced, really, from physical health care. Now, I know in the Department of Psychiatry here, they're working very hard to integrate a program of mental health care into primary care, and that's really the direction that we're going to have to take. But meanwhile, our healers and traditional healers in the developmental world deal with all aspects of personality. They might talk about spirituality, or might ask about family relations or social influences on health. But here in the United States, if you're physically ill, you might go to a doctor. If you want to talk about a spiritual problem, you find a rabbi, a priest, or someone. You might have to go to someone else, a chiropractor for something else. There's separate healers. It's not very holistic in terms of the care. Another hallmark of Western psychiatry is really highly trained professionals. A psychiatrist has to undergo rigorous training for 12 years. And this is after a high school degree. 24 years of training. It reaches close to the life expectancy of some adults in countries. There's no way that they're going to be in school for this long. There's also dependence on psychoactive medications. These can be expensive, not very available, and have to be prescribed by someone with these 24 years of experience or a physician. Is the West relevant for the rest of the world? There's a thinking that we don't need sophisticated and complex diagnostics that are only delivered by highly trained specialists. In fact, the World Health Organization, the WHO, came up with an intervention guide that really distills the 1,000-page tome into about 100 pages. It extends competence in diagnosis to people who are non-mental health specialists, and it uses flow charts that can be easily followed. Can less be more? Another WHO official says, is it possible that a mental health system, which is poor, deprived, with no resources, no drugs, is providing better and more humane and sensible service to the population rather than in rich countries? In a word, yes, it can happen. In study after study, they're finding in developing countries that strong family connections and ties can lead to lower relapse rates among people, even with severe mental illness, when there's no access to other formal psychiatric care. So things can be done better in a less complicated way. Also, we have to value indigenous knowledge to learn more about and respect local and indigenous ways of being. And there's a two-way knowledge exchange. We can't just go in the West and think that what we've done here is going to work. Using more holistic treatments, studying local healing traditions, including spiritually based traditions. We need to make the care less individually centered and inclusive of family and community where people are mainly treated. What about adapting interventions? If we do it, we have to do it carefully. Now, there was one idea, a very expert team that was studying reactions to trauma, and they were using pet therapy in the United States, and a lot of success using dogs. Well, they exported this over to Iraq, and they got there to find that in a Muslim country, dogs are unclean, and people are fearful of dogs. It's a disaster to have a program that couldn't get off the ground. But here in the Department of Psychiatry, there are people doing much more careful work. Deb Kaysen's working in Iraq, the Congo, and Kurdistan, Iraq, on post-traumatic stress disorder treatments. Shannon Dorsey couldn't be here tonight. She's abroad, is doing trauma-focused cognitive behavioral therapy with kids. And Lisa Manhart and Deepa Rao in the Department of Global Health and EPI are looking at depression assessment and stigma reduction in India and doing the very careful qualitative work that's necessary to do this. There's also a movement for task shifting. So basically transferring these very highly specific tasks, these kind of complex diagnoses, and getting them to work, getting health workers with much less training and fewer qualifications to do it. Now, who are these other people? They might be peers that weren't trained at all. They could be family members, supporters, partners, paraprofessionals, or other health professionals who can work in the field. Finally, we need to exploit technology. Now, Dr. Van Dyke talked about some of these, but there's also smartphones and pagers, online social networking where people can get together and decrease stigma. We used to have self-help groups face-to-face. Now you can do them on the internet. They can be computer administrator interactive counseling. This can be done with a counselor on the other end, or a completely interactive way with no other human being involved in it. There's virtual reality psychotherapy, interactive voice messaging systems, biofeedback, asynchronous online support groups, and just email and video phone with psychotherapists. So a lot of technology that can be used. And a therapist doesn't have to be 50 feet away or in front of the person. It could be across the world and still provide the service. Next, I want to talk about some research that I'm doing at the Department of Psychology here at the University of Washington, and some of the research contributions in terms of global mental health. Mainly, I work on projects to design and empirically evaluate behavioral interventions to promote health. I'll talk about 3 today, the ones in the urban centers in the U.S., some in Beijing, China, and one underway right now on the U.S. Mexico border. First, I'll give you some background, as most of these talk about HIV and AIDS. About 33.3 million people are currently living with HIV in the world. It's really the modern plague. You can see that most of them are in sub-Saharan Africa, about 22.5 million, very few actually in the United States, where most of the resources are committed. But there's a growing epidemic in Latin America and also in Asia, where huge population growth is threatening worldwide implications of that. When you look at the very recent diagnoses, those in the last year that it was recorded, 2009, 97% were in low and middle income countries. This really is an epidemic of the developing world. 1,000 in children, and many that aren't adults are young people, 15 to 24 years of age. In 1996, there were very encouraging headlines. There was a cure for AIDS. And what it was the advent of highly active antiretroviral therapy. It was shown to have drastic improvements in health outcomes. And in fact, David Hu of the Aaron Diamond Foundation was named the Man of the Year by Time in 1996. And this was initially followed by a very precipitous drop in death rates. And you can see here across the years 1987 to 2006, that the deaths per 100,000 population started out 6, was on a steep incline until the development of retrovirals, and it just plummeted, and it has stayed low actually ever since. The dark side of this, though, the other side of this was that you actually need incredibly strict adherence to be able to stay on the medications. Some of the early reports said up to 95% of your medications. If you took anything less, or you even had a brief drug holiday, went away for the weekend, forgot to take your meds with you, you could come back and they might not work anymore. They would become resistant to the virus. And any of us on a penicillin regimen for 10 days knows that it's darn hard to even take every one of those 10 pills. To try to do this and to have to be on it indefinitely is very difficult. There's a lack of initial distressing symptoms when people start, and they're starting now to say hit hard, hit early, as soon as you get the diagnosis. Now in San Francisco, it's being offered to anybody with an HIV diagnosis. You're not feeling so bad when you first get HIV before the impact of the disease, and it's difficult to stay on a regimen that actually makes you feel worse because there are side effects very early on and some more serious ones later. There used to be more dietary requirements and restrictions. These are easing up with the less toxic and the newer forms of the medication. So the first project I'll tell you about is Project PAL, Promoting Adherence for Life. This is an NIMH-funded project that took place for 5 years here in Seattle. And what's the context for going in here? Well, we started out in the Bronx, New York, did the pilot study, and then came in Seattle and saw similar problems among HIV-positive persons. They were challenged by things like substance use, trauma, high rates of trauma, about 65% had been sexually abused in one sample, poverty, mental health issues like depression, anxiety, and many were sexual, racial minorities. They were marginalized in society even by their own families, extremely isolated. They were having a lot of difficulties adhering to these HIV medications, even though they were life-saving. So what was our approach? We proposed to try peer support and pager text messaging as a way to provide social support and improve medication adherence. They could be, if they were successful, we thought the idea was they could be widely disseminated, easily disseminated to other places without a lot of resources. So who are our peers? We trained HIV-positive patients from Madison Clinic right here at Harborview Hospital and matched the following criteria. They had to be adherent, first of all, to their own medication regimen. They had to want to participate in initial training and ongoing supervision. They had to be socially skilled, able to commit for at least 6 months, and referred by themselves or a doc. So what did the peers do with patients? They had meetings every other week where they would discuss their adherence and problem solve around life issues related to HIV and adherence. In weekly phone calls, they would actually talk on a one-on-one basis with a peer that was assigned to them. This is great for people who are concerned more about stigma, couldn't make it to the clinic, made it much more accessible. The pager intervention was also a 3-month intervention, and patients in this arm received daily individualized text messages with specific medication reminders. It's 8 o'clock, take 2 of the red pills, so it was confidential, it didn't say take your HIV meds, take 2 of the red pills now. We also had occasional educational and funny messages. We thought they were funny when we saw them. Some of the participants didn't think they were as funny as we did. But the idea was to lessen the seriousness of always having the page mean this is something about your illness. In the end, 224 adult patients receiving primary HIV care were recruited. They were recruited through a study nurse, so we provided referrals. They used computers to sit down at the clinic and answer questions. We find that it's easier with the computer than face-to-face to give some more accurate answers about some of the sensitive questions we asked. And we asked them about their medication adherence. But it's very hard to remember what your medication adherence is over any length of time. If I asked you all, what did you have for lunch 2 weeks ago? I have no idea if you even ate lunch 2 weeks ago. And to ask these people, did they take a pill 3 times a day 3 or 4 weeks ago? It's just very hard. So there's a technology that helps with this called an electronic data monitoring, where we use the MEMS caps. And it's a very clever cap that has a microprocessor on top. And every time you unscrew the bottle to take a pill, it gives you the exact date and time of that opening. So we come back to the office, hook it up to hardware in the computer, and it gives out a printout of their adherence. We tell them what we're doing and that we're using it, by the way. It's not like it's a secret and we don't find out. So this study went for 3 months. They were paid to participate for the baseline, for assessments at the end of the intervention and 6 and 9 month follow-ups. They got a $35 bonus if they didn't lose the cap, which cost us $85. And we did pay them to come to actually the meeting for some of their transportation, the travel that was put in. In the end, they could earn up to $240 for participating in the study. The results, did the intervention actually help people take their meds or improve their health outcomes? It looks like pager support. I'll walk you through this. If you had a peer, it's in the red. In 3 months was the first session. So if you had a peer, it looks like your self-reported adherence was about 10% higher at the end of the intervention. Now, over time, every study of adherence shows that over time, adherence tends to decline, and you see this in this trial. So by the end, it's not much different. In terms of the pager support, they started with a little higher adherence, but it dropped pretty much the same, or a little bit higher over the time that the intervention ended. And actually, towards a follow-up, we're doing a little bit better than people that did not have the pager. We only gave them the pager for 3 months and took it away at the end. What about the drug monitor adherence? These were the MEMS. So peers had an effect, had a small effect on adherence, but not the pagers. So you can see the peers here at the end of the intervention. This is a 3-month period. The peers have a higher adherence than those without a peer. Though over time, both of them tended to drop. Not as much of a difference in the group with a peer and pager. And I forgot to show you that the rate of adherence is much lower, of course, when it's objectively measured than when you ask them about their medication adherence. What about health outcomes? Peer support didn't seem to have much of an effect on viral load, which is the amount of HIV in your blood, or immune functioning, which is your CD4 count. The pager messaging did, and it seemed to have an effect past the intervention into the follow-up period. So people who had a pager had decreased levels of HIV in their blood and improved CD functioning up to 6 months after the intervention was over. Also, we found out that the more you participated in these things, the better you did. So the greater attendance at peer support meetings was associated with less HIV in the blood up to 6 months after the intervention. This is controlling for baseline levels. Also, a higher pager response rate was associated with less HIV in the blood and greater immune functioning, again up to 6 months after the intervention. We were pleased to see that the CDC recognized both of these strategies as interventions with good evidence. And they did a review of the literature from 1996 to 2009, and these are 2 of the few that they were able to find. It's very difficult to change people's adherence, even when it comes to taking medications that are saving their life. So our conclusion in terms of our global mental health focus, task shifting appears it can work. You can train people with HIV to provide support. They can function face-to-face via telephone. And in terms of the technology, we can use these pagers to supplement the human contact. They can be highly automated. No one was sitting there setting up these pages. It was all done with a complex software system. And it's increasingly available and affordable. Since we've done this, the price of the pages have come way down. And many people have their own smartphones. Just want to give the nod to the study team. It takes a village to do any of these studies, and particularly Matt Cooten, who was the director of the clinic at Madison when we did this. Next, I want to talk about our work in China. We had a project called Adherence Research in China, or Project ARC. It was a collaboration among investigators at the University of Washington, China CDC, in Beijing's Dintan Hospital. It's also supported by the NIMH. It's a 3-year project that recently ended. Let me tell you a little bit about the HIV epidemic in China, because it's slightly different than the United States. There are about 700,000 people infected, but about 80% have no idea. They haven't had an HIV test. They don't know where they're at risk. 30 to 50% annual increase in reported cases. So it's very scary to think of the epidemic taking off here. There are different epidemics in China, too. One is related to blood selling in Henan and other provinces. Basically, blood selling is illegal, like it is in the States. You can volunteer and donate to give blood, but many people don't because there are cultural prescriptions against it. But very poor often do to make money. And the way that they collect the blood is a very efficient system of spreading any blood-borne illness. They basically take all the blood out, pull it together, extract the plasma, and put back in the red blood cells so you can donate more. And it's any illness you can get. Their communities at 90% are infected, so it's really been a horrible tragedy. The second epidemic is through injection drug use. You can get HIV through using injection drugs in southwestern provinces is where most of this is seen. And then there's sexual transmission, both heterosexual, often in married couples, and men who have sex with men. I don't say gay men, because a lot of the men in China don't identify as being gay or homosexual. They're married, they have children, but they do have sex with other men. And since 2004, the Chinese government has made available free antiretroviral therapy to people who need it. Just another map of China. You can see we're up here in Beijing. It's where we worked. Henan is where the blood selling was taking place, and it's in southwestern China, Yunnan province, where you see a lot of the IDU epidemic. So the context, huge stigma of HIV. Reminds me of the distress that people felt in the 80s, the phobia about AIDS that you saw here in the United States early on. Isolation, distress at initial diagnosis. One family got a diagnosis and then moved 1,000 miles away, our husband and wife, to live in an apartment by themselves in a city where nobody knew them. And that was their daily life, just living in that apartment, didn't talk to anybody. In a collectivist culture, entire family is often shamed and affected. And all these factors really impeded adherence. On top of that, China had very little personnel, no social workers, no psychologists, psychiatrists, forget it, to address the non-medical aspects of patient care. It was all done by physician providers. On the plus side, though, always look for the resilience in the community. There's exploding technological access and use. So we thought about these factors when we went to China. A leader at the CDC said that China has recognized its HIV/AIDS epidemic as a serious health, development, economic, and security challenge. Resources related to enhancing antiretroviral therapy are urgently needed. With this as the background, we went in with a 2-phase project. First, we wanted to conduct qualitative interviews. We talked to families, we talked to people with HIV, and we said, what are the barriers to taking adherence? What might make it easier? What strategies do you think will work? And then based on what they said, based on what we learned in the West, we adapted a program that would be culturally sensitive and had theory behind it. We pilot tested it in a randomized controlled trial with 2 arms. What were our strategies overall? First of all, to be culturally appropriate. And how do we do this in this culture that values the family so much? We said, bring your family in. Do you have, instead of using a peer, because there's such high stigma, we said, bring a family member in. You have an adherence partner, someone that's working, living with you and can help you with your meds. Bring them in and we'll train them how to provide the best support to you. We gave them choices to accommodate their preferences. If you want to use a pager, good. Your own cell phone, great. You don't have to take ours. We leveraged existing resources. There is a Red Ribbon Society or a peer support program that's very strong in China, and we use this. We took advantage of the nurses who pretty much were doing some of the paperwork at the hospital. Although they were trained, they had very little patient contact. But they were wonderful people, had a great relationship with the patients, and they jumped at the idea to be able to do something more. I said we involved the family, cell phones, and we used approaches found to be successful, at least in the West so far. And we created an intervention that hopefully other clinics can reproduce. So in this nurse counseling program, we trained all the nurses. Everybody wanted to do it, whether they were going to be in the study or not. They thought it was great fun to go over there. It's a week-long program to be trained in the counseling intervention. And it was based on Steve Safran, who's at Mass General Hospital, Harvard, his Life Steps model. And the idea is to enhance their motivation, learn skills, be able to problem solve around adherence. And they could, or if they wanted to, have a didactic program where they brought in another person with them. So I won't read through all of these, but basically there are several components, counseling components. Again, they've focused on problem solving and being able to take the pills, dealing with getting to appointments, handling the slips and relapses of non-adherence. And most important was this family, community, social support, and privacy issues. We had to add this as part of the intervention because it didn't exist in the way it was written up in the West. A very important part of it. This is our nurse Wang, who has delivered most of the intervention. She was very popular with the patients, did a wonderful job. The electronic reminders. were just a simple alarm device with an audio reminder, and they were first offered the choice of this, or they can use their cell phones, which most of the people had and actually chose to use. So we had two arms. We chose a minimal and an enhanced intervention. We didn't want to just say no treatment and some treatment, because they were getting some already. So we referred to the peer society. They had a simple plastic pill box that they could use to help take their pills, and they all got education around the importance of adherence and taking their meds. And in the enhanced arm, we did all those things, plus we added the alarm and or the counseling program. We collected data at baseline, the end of the 13-week intervention, and 25-week follow-up. We also had phone survey check-in with them. We used the MEMS caps once again, and we used blood draws to find out again about any biological markers of success. The results? We have found that better 30-day self-reported adherence. You can see here the enhanced intervention is in the blue. So even though they started with lower adherence overall, over the course of the intervention, they do much better. Whereas if you you just got the minimal intervention, though you started out higher in adherence, you actually decreased over time. They even showed, according to the MEMS, the electronic adherence, that it was slightly better. So those getting in the enhanced arm tend to increase their adherence during the first part of the program, where the others went down. Over time, though, it's very difficult to sustain those gains, and in both arms, they decrease their adherence. We also found a biological marker effect. So if you look at the minimal arm and then the enhanced arm, so these are the ones getting the full intervention, they had a greater drop of HIV in their blood. It wasn't sustained, just a little bit less at follow-up. Again, it's very difficult once you take away the intervention to sustain an effect. And we found that the immune system was affected. So those in the enhanced arm versus the minimal arm had higher functioning in terms of their CD4 counts at the end of the intervention, but not at the follow-up. Conclusions. Looks like you can adapt a problem-solving and counseling intervention for Chinese patients. The nurses were receptive to training, loved it, did a great job, and the Chinese patients participated in the counseling. We weren't sure they would do that at first. We went to China, and they said it's a very private society. They have an expression in China. When Westerners open their mouths to talk, you see all the way to their stomachs. They tell you too much. Shut up. TMI. And when we go to China, would they talk with us? Would they talk to the nurse about something as private as this? And they did. Yeah, sometimes didn't talk to each other. We had cases where the men who had sex with men would come in and had infected their wives and didn't tell them how they got infected. So women would want to know how. Did you go to the dentist? What was it that caused this? We couldn't say anything, of course, out of confidentiality, but at least they were willing to talk to us. We also learned that technology can really bolster the intervention. Again, the Village of Collaborators, I particularly want to point at the China CDC, Zheng Fuji, and Zhao Hongjing, the nurse director who was at the clinic, were the major players on the China side of the project. So next steps in China, I've written for an award to start using technology. So we can use computer-assisted interventions to address distress at the initial diagnosis. They went back to China, we gave them the result, and it says, good, we're really glad that people can do better with adherence, but we're just overwhelmed with the psychological distress of people being suicidal when they come in with their illness. What can we do? We don't have, it's harder to train the nurses in doing that. So the next idea is to kind of figure out how we can use the computer to help the nurses provide the treatment. We also want to look at, to decrease stigma, the social networking via the internet. A lot of the folks are very isolated in rural communities, and we thought if they could talk to other people on the computer, that takes away a lot of the stress, a lot of the trauma of the initial diagnosis. Finally, I want to talk about the project on the U.S. Mexico border, where we looked at mental health and HIV. This project is called uwvideo, New Day, and I was proud to say it was a participant who came up with this idea and the logo that represents the El Paso community. It's a 3-year study, also funded by NIMH, which is ongoing right now, to address depression and HIV medication adherence in men and women who are Latino adults on the U.S. border. So what's the context in El Paso? Like China, the border region is marked by a growing epidemic, huge stigma, a strong collectivist culture, and a lot of anti-gay sentiment. But also, here on the border, there are high rates of poverty. There's racism, discrimination, even though the city itself is a majority-minority city. Frequent binational crossing across the border, and now this increasing violence in Juarez and the city of Chihuahua, the state of Chihuahua just across the border. Bilingualism, which is an issue because a lot of the care is provided only in English, and sometimes a non-dominant language is not very good. There's limited access to services, especially on the Mexico side, and high religiosity, which can be a strength in some ways, but increase the stigma in others. Also, there are huge rates of depression. William Starone has written very movingly about his own experiences with mental illness. He says the pain of severe depression is quite unimaginable to those who have not suffered it. and it kills in many instances because its anguish can no longer be borne. The prevention of many suicides will continue to be hindered until there's general awareness of the pain of depression. In the general population, maybe about 15% will experience a major depression in their lifetime, but among people with HIV, it can be double or triple that rate. And it was a severe problem in El Paso. We came there to do some community work first to find out what the objectives of the study should be, and they all talked about mental health and depression in particular. We did some pilot work, and about 33% of the people we saw in the clinic had a diagnosable mood disorder, mainly major depression. So what could we do in this context? Well, again, we looked to an empirically supported cognitive behavioral therapy program. Again, this one was by Steve Safran at Harvard, for HIV medication adherence and symptoms of depression. He combined it together. So we would have weekly sessions for 4 months with booster sessions. We learned from our other work that over time you see the lapse in the findings. We had booster sessions later on. And it had several modules, some psychoeducation, some motivational interviewing to increase commitment to adherence, how to do the training, how to adhere, how to change cognitions that were interfering with people's ability to decrease their depression, even relaxation training. We also used some behavioral activation as well, getting people to schedule events that they were found pleasing and pleasurable as a way to decrease depression. And we wanted to train non-professionals. There aren't a lot of psychologists. Actually, in El Paso, in the city of about 1 million the size of Seattle, there were 3 psychologists who spoke Spanish. 2 of them had their license taken away and moved to El Paso to work. And we wanted to pilot test this intervention. So our methods, we recruited participants from La Fe Health Clinic. They had to be depressed and non-adherent with their medication. They were randomized to a 6-month treatment or usual care. Again, we used the MEMS caps. And we also assessed depression with a self-report BDI and a clinician-administered MADRS. It's one of the pharmacies there across the border. Did the intervention work? I have a shrine here which reminds me how much we prayed that it would after getting this off the ground. But it's still an ongoing trial. But so far, the people in the CBT, this is the intervention trial, they started out with higher depression, and it seemed to plummet during the course of therapy. The control condition was low and stayed low throughout. In terms of the MADRS, again, this is a clinician administered. We didn't just ask them about depression. We actually rated how they responded to certain items. If you were in the intervention condition, you started high on your depression. Again, it plummeted during the course of therapy. Those in the control condition started low and actually increased in terms of their depression without getting the therapy. The self-reported adherence, this is just the kind of chart you want to see, starting lower in the control group, but actually ending up higher. In the intervention group. So if you got the therapy, you did better in terms of your self-reported adherence. The controls started high and just dropped precipitously during the course of the trial. This is self-report. They're acknowledging they didn't take their medication. We don't have enough data yet on the MEMS caps for this group. So our conclusions, you can adapt an intervention developed and tested in a white Western context for Latinos on the border. The intervention we found was feasible. There was high interest. There was low attrition. There was some attrition. It's very difficult to do a study with a depressed population. But then there were challenges. There were literacy and language issues with some the CBT content. Specifically, some of the people, we had one person in particular had really low literacy. He actually didn't read at all. He had never been beyond the first grade. What we had to do was to have pictures of everything and use graphics with him. A lot of them had problem with the homework assignments. I have the same problem with my 7-year-old. So I don't think this is a very culturally specific aspect of doing homework in the intervention, but it is something that was more difficult when people complain, particularly in this population, that it's hard. So we found that you have to take into account the stigma of HIV and homosexuality, the importance of family and religion, and multiple other stressors. And again, this intervention that was originally tested in the West, mainly with gay white men, none of these issues were as a concern. Here on the Mexico border, it was very important. People talked about a lot of the gay men lived with their families, even as adults. There was no role for them to marry another man and start their own life. So even in their 50s, they were with their families. And they didn't tell their families that they were HIV positive or that they were taking medication. So it's very difficult to take a medication 2 or 3 times a day to take care of a chronic illness when your own family doesn't know about it. And then generally, the family was a strength for people living in this community, although sometimes they complained there was kind of an enmeshment in the families. And one man very proudly said he'd had enough of his family and he moved away. He needed this separation. We found out later he moved 5 miles across town. And that was the separation that he had found. That was drastic for him, and he only saw them once or twice a week. The next steps on the border are to look at stigma. Stigma is a huge problem, as I said, both in China and here. And we're thinking about using a photo voice intervention. What is photo voice? It's basically taking pictures, giving folks a digital camera, having them take pictures, and combining it with social action. So they take pictures to document their lived experience of stigma and HIV. It promotes a critical dialogue and knowledge through discussion. They do it through small groups. And we're hoping to make this a little more psychologically sophisticated than what has been done in the past. And the idea is to reach policymakers and others through some kind of direct social action or through gallery exhibitions where they show their work. And interestingly, this technique is first started in China when it was used in Yunnan province, when Mary Burris looked at reproductive health decisions and situations of women, of poor women. So we're thinking we might end up using something like that in China as well. Again, the acknowledgement is funded by NIMH. I want to point out specifically to my colleague, John Wiebe, who's the principal investigator of the El Paso site, and the La Fe Clinic and staff. Okay, I want to end with talking a little bit more directly about the global mental health movement. When Gandhi was asked once to comment on Western civilization, he said he thought it would be a very good idea. I think we can say the same thing about global mental health. It would be a great idea, but we're really far from achieving it right now. Dr. Arthur Kleinman, who is a psychiatrist and an anthropologist, who's a pioneer in the global mental health movement. For 20, 30 years, he's been writing about international work. A little trivia, he's an illustrious alumnus of the University of Washington. He actually began his work in China while he was here. He's written poignantly about some of the just degrading conditions in which people with mental illness live throughout the developing world, some chained to places so they won't escape. And in the last week, two major national outlets wrote about mental illness in the developing world. One was in CNN Online. It wrote about Kenya, the mentally ill, and they had a story about Thomas Matoke, who was 33. They said he's tied to a steel bed frame with a piece of rope surrounded by pools of his urine. His mattress is soiled and ripped to shreds. He can't speak to tell his mother what he wants or feels. He's alone in his world of screams and agony, and he's been like this for 30 years. Some of the Kenyan experts that were asked to talk about it called the situation catastrophic. So there were millions of people like this, and noted that only 1% of the healthcare budget in Kenya goes to mental health issues. A day later, in the LA Times, there was a special on China's disabled who are exploited as slaves. So an economy where manual labor is in demand, ruthless recruiters often prey on the mentally disabled. The man showed here was held at a brick kiln and is one of countless slaves who endured torture in deplorable living conditions until he was rescued. Others fare worse. In 2008, a brick factory owner beat a young man to death for attempting to escape. Young women have been sold by psychiatric hospitals as sexual partners and wives. And others are kidnapped and taken thousands of miles from their home to work in factories. This man has been searching for his mentally impaired son who was kidnapped 2 years ago. Still every afternoon he goes out with posters looking for his son. Kleinman wrote about the moral challenge of global mental health. He said, any improvement in global mental health will require a moral transformation, just as the foundation for reform, just like has happened with AIDS. AIDS medications were $20,000 a year in the West. People got together with activists, mental health and policy community, and said this can't go on. And now they're available for dollars a month in the developing world. I think eradicating global mental health inequities is arguably one of the most compelling moral issues of our time, and it's been called one of the last frontiers in the improvement of the human condition. The WHO has been very concerned about this over the last decade, especially. They've written about protecting the human rights of people with mental illness throughout the world, and they have programs such as Human Rights, Human Wrongs, The Time to Act Is Now, Mental Health, No Health Without Mental Health, and then the Mental Health Gap Action Program to scale up treatment for people in the developing world. And they have several strategies to try to pursue that. Try to promote community-based approaches, which we've talked about, work on stigma reduction any way we can, to target societal and political issues, and to work with the most underserved populations to have the most impact. There's also, for the first time, the UN General Assembly's adoption of a resolution on global health and foreign policy highlighted mental health as a major area of importance. That's a major change. And there's a movement for global mental health. An online community of professionals have been brought together and is expanding. I listed the website here, globalmentalhealth.org. They have yearly conferences and are trying to increase awareness of global mental health. The psychiatric community has always been very involved in global mental health, and recently even more so. They have a set of agenda items for prioritizing mental health and developmental aid programs. And I think this is the next step in terms of global mental health. And they said we need to formulate a clear-cut message. That 1,000-page tome of the DSM, that's not helping. That's not helping people. We need to prioritize key disorders, show the impact they're having on life and on productivity in the developing world and focus on them. We need key stakeholders at all levels to help us develop a strategy. We need to work with local people. We need to involve people who have experienced mental illness. They're incredibly important advocates and activists. We need research to shape on factors that shape the political will. Basically, we have to do marketing research. How can we change people's attitudes about this? We need to track the governmental rights declarations so we can show other countries what's being done. And we need to develop best practice, and not only just work that are effective, but are cost effective. We need to train the media. You saw those 2 reports that came out in the last week. Those have an impact. We need to teach them about the relevance of mental health to aid organizations and the need for positive portrayals. Because when mental health is portrayed negatively, like it often is in the paper, someone killed someone in Tucson. It's often a mentally disabled person, and then it's seen as all mentally ill people are violent or they're somehow responsible for what they're doing. And finally, increase the advocacy of NGOs. They're doing tremendous work at advocating. They work directly with people living with mental illness. But we need to increase the effectiveness of what they're doing. When I think about what are the professional and personal values we need to succeed in this work, I think about the values of hubris and humility, kind of 2 sides of the same coin. When you look at the daunting global challenge, you think you do need extreme pride, self-confidence, really an overestimation of your own abilities to even approach this. I think I named my talk, How to Take Care of Global Mental Health. Of course, I can't do that, but you got to start somewhere. It takes hubris to jump in. And then humility. When you look at the history of what we've done, the mistakes that we've made, we were the ones that first imported these psychiatric hospitals where people were locked up and put away. You've got to have modesty. You've got to have some humbleness about what you can do. And you have to be aware of your own limitations and realize that we're going to work successfully. We're going to have to do it in partnership with people and not think that the best ideas come out of the West. That white is always right. I'm going to end with a call to action. I have to acknowledge this is the same call to action that my local health club uses, and it did work for me. I'm now a member, and I'm hoping it'll work for all the work that has to be done for the community. Researchers are needed, like some of the work I talked about now, the ones that are here at the University of Washington, for example, doing this work. The academic administrators who need to make this a priority for research in terms of hiring and support. The students, so many of our students now are looking at global mental health as a future career. We can't keep up with the need for classes. There are mental health personnel who have to work together with traditional healers. The NGOs, the community-based organizations and nonprofits who often set the agenda for aid and implement the aid when it's there. Compassionate lay individuals, the activists in general, and basically all those affected by mental illness, either themselves or through those they love, which is for the most part the rest of us. Thank you.
Thank you, Jane. That was a great talk, great presentation. Yeah, you're right. It's such a huge problem, and it's very daunting. And then it's very encouraging, though, that there are some groups like the WHO are taking steps. And so are there any indications that the steps that they're taking are having impact, or do you think that it's still so small that it's just not scratching?
I think we're very early in the process, but I think the excitement about a talk like this and the research that's been done, even just at the University of Washington, shows there's interest, and that interest is the beginning of something happening. But I'd like to see an impact on some of the statistics that Dr. Van Dyke talked about to really see the impact.
The question up here?
Hi, I know that the global mental health movement is very much influenced by the success of the HIV movement, which was treatment now, a unification. Can you say a little bit about how you'd like to see that applied in the global mental health common movement?
I know, I could go back to what the call for the 7 steps to look at. This is kind of what they did with HIV, right? They had a clear message. People are dying. You can take a pill. It can work. And they had a few key leaders, people like Paul Farmer, stating the way, saying this can be done. If we have a political will, we can work together with communities and the pharmaceuticals and policymakers to say that we can change the laws. We can use the generic drugs even before the patents are done, because this is a humanitarian crisis. So there was a level of awareness raised about it. They had activists from the community. Actually, they've done all of these things to be able to do it. And it was just such an incredible success. It was hard for people actually, even in the HIV community, to believe that it could happen so quickly and that they did it so well. So I think it's a great model for us in mental health.
And I want to thank you all for coming out tonight to enjoy these lectures. Thank you.